My name is Dr. Ed Shahady, and we're here at the Cardiometabolic Risk Conference in Las Vegas, and I have with me Dr. Steve Milligan and Dr. Ben Taylor. They just had a nice discussion on initiating insulin, so that's what we're going to talk about. So Ben, I'll start with you. I want to start as a clinician, and as you do as a clinician, start patients on insulin. So what are some of the indications for starting somebody on insulin?
Well, when someone is not becoming to target range of their glucose levels, would be then probably one of the biggest indicators to start insulin. If there's somebody who's not very motivated to stay on their oral anti-hypoglycemics, that would be another one. Those are the two big ones I look for.
Okay, you're talking about type 2s.
Type 2, yes, sir.
Okay, and that's most of what probably we're going to see. All right, but it's occasionally the type 1 in the primary care.
Correct.
Okay, what about the downside of insulin, Steve? What is that?
So downside of insulin, there's a couple, and the two big ones are the risk of hypoglycemia is the big one, and then weight gain is another one.
Okay. So think of that. Okay, so that's that typical type 2. Usually what's happened, I've got them on an oral. And then, after a while, their A1C starts to rise, especially metformin or maybe sulfonylurea. So what do I add? Do I add a regular insulin? Do I add one of the newer insulins? Do I add a basal insulin? What should my choice be?
You should probably start with a basal insulin.
Okay.
And see how they do after 2 or 3 months on that.
How do I do that? What are some tricks with the basal insulin starting?
Well, you can start them off at 2 to 3 units and then have them check their glucose like every 3 days or so.
Okay.
And see if you can increase their
What time of day do I check my glucose? Is it fasting?
You can check it pre-meal and after a meal. Postprandial also, you can check it either one. So you want to just make sure that their glucose, because they're going to be kind of swinging out there at first when they first start. Okay,
so I start then I just increase my insulin dose based on what my morning insulin is. If I'm giving an evening basal, is that sort of the way I do it?
Correct.
Okay, very good. Okay, so how high do I go with a basal, Steve? But this over-basalization, can I get in trouble with too much basal?
The reality is you probably can't, but what you're looking for is you're looking to try to get that hemoglobin A1C down to about 7.5. If you can get it there, you've probably maxed out the basal dose, and then you need to make the switch to, if they're still above 7.5, you need to make the switch to a bolus dose with their biggest meal.
Okay, so let's talk about the average patient. Say they get, they're at 8.5. I've had them on metformin, and I decide I want to go with insulin, a basal insulin now. How many will I get down below that 7.5, just adding the basal?
And I would tell you, you're not going to get very many down below the basal level. Below the 7.5 with just a basal dose. You're going to get some, and you're going to get the motivated patient who is actually doing the stuff you want them to do, diet, exercise, etc. If they're doing that, you've got a better chance, but the average patient, you're probably not going to get down below 7.5, and you're going to have to consider adding a different version of insulin.
Okay, let's talk about the GLP-1 receptor agonist. Now, some people would say, okay, you got my orals. I failed my orals. Now, do I add a GLP-1 receptor agonist or do I add my basal insulin?
You can do either one. It just depends on the patient. And like Steve said, most patients, you're not going to get them down below 7.5, and there's not a whole lot of motivated patients out there that really want to do what they're supposed to do. As we just discussed in our lecture there, only probably less than 60% of the population will be a good proponent of that. So you can start either one, and you can add on the GLPs and see how they do on that for a while. And if they start to fail that, then you probably should go ahead and start them on a basal insulin.
Okay, all right, so you could start the GLP. Some people would like that, some people would like that.
Yeah.
Okay, I'm gonna go with this now, Steve. I start on a basal insulin, and say I'm getting pretty high. I'm up to 40 units of the basal insulin, say glargine in the evening. What about adding a GLP-1 receptor now? Because I'm not going to get hypoglycemic, pushing that, so I might add the GLP-1 to the insulin, plus maybe my orals, or is that too much?
I don't think it's too much. I think you can do it. I will tell you cost is going to be an issue. The combination of obviously metformin is relatively inexpensive, but if you're talking about a glargine, like you said, and then you start talking about a GLP-1 on top of that, cost is going to factor into it. So the issue is going to be, do I just keep going up on my basal insulin, or do I keep it where it's at and add a GLP-1 on top of it? It's going to be, you know, up to you and the patient discussing the cost factors.
Okay, good point. Okay, go back to the insulin, and I want to keep upping that. At what point do I say once a day versus twice a day? Like I've got them on 40 or 60 of glargine, I said, I better divide this dose. Is that reasonable, or just keep going high on the once in the evening?
No, you can, once if their blood sugar level, the A1C is still climbing, you know, after 2 or 3 months, you're still checking in, their fasting blood sugars are still climbing, then you may want to go up to a second dose.
Okay.
But if they're staying below 7.5 or so, leave them right there. Don't mess with them anymore.
All right, okay. So given a twice a day dose is reasonable.
It's reasonable, yes.
Okay, let me switch it a little bit. So newly diagnosed diabetic, very high, 9, 10 A1C, and type 2, but more likely type 2. What about the idea of starting them on insulin, really blast them with the insulin, getting that A1C really down, and then I can stop the insulin and go with orals, you know, get rid of that lipo and the glucotoxicity. Because some people write about that. So what do you think about that, Steve? Is that a good option? Initially use insulin and get them down to where I can use lifestyle and orals?
Absolutely. I think that's a great option, specifically if the hemoglobin A1C is above 9. And I think the American College of Endocrinology says one of the indications for starting insulin is a hemoglobin A1C above 9. There's actually decent data out there to say that you start them on insulin and you get them 2 weeks of being euglycemic on the insulin, stopping it, and then doing diet and lifestyle, you may be able to maintain that euglycemia for a year.
And I presume that's with people that this is their initial onset. They haven't had it for 10 years.
No, absolutely. This is the
Absolutely,
initial
yes.
onset.
Right.
Yes.
Okay, you want to add to that your experience with using insulin initially and not being able to drop it?
Yes, I've done that in the past, and it's worked really well for me. And the patient had no problem. And I got them to become very active and start watching what they're eating, and they start losing weight, and they were good.
All right. Wait, you talked about something really, okay, so I started, like I got a patient I'm going to work with when I go back, and that's her problem. She, you know, she got started on her insulin. She's young, she's 45. I don't really know if she's type 1 or type 2 or to do that. But she is discouraged because she's gaining weight. And she's both on a basal, you know, and then a basal, you know, bolus insulin too. So what do I do to help with not gaining weight while they're on insulin?
Well, first of all, you have to talk to your patient to see, are they active? Because if they're not active, they're going to gain weight. You know, and if she's still hormonal, she's going to gain weight. There's nothing you really can do about that one. But if you can get them active and start cutting their carbs some down a little bit to manage it, they're going to lose weight. You have to be patient. I tell my patients, you have to be patient. Don't be in a hurry. You're not going to lose 20, 30 pounds all in 2 weeks. It's not going to happen.
Right. You want to add anything to that, to the weight gain?
This is a very active field right now. I think Ben brought up in our discussion that metformin may blunt some of the weight gain that you have when you give insulin.
All right.
Depending on their weight, if they're in a specific category of BMI, there's actually data out there suggesting that even bariatric surgery could help lose they could become less insulin resistant by getting them to lose, and it is becoming an indication for bariatric surgery.
Okay. Well, very good. This is fascinating. You guys really enlightened the field a lot. We appreciate you being here. Thank you very much.
Thank you for having us.